Good afternoon, everybody. Happy Juneteenth. Today is June 19th, 2020. It's currently 1 o'clock in the afternoon. You joined us for the CAF COVID Weekly Roundup. Today, we're going to talk about a small portion of updates that happened during this week. Thankfully, these AFLs that come out so frequently have kind of slowed a little, so we've not had to dive in depth in each one of these changes, and it's allowed us to bring on some really fantastic speakers to talk in depth about some of the issues you guys are facing. With me today is Karen Tynan and Kevin Bland. Both of them are attorneys. I won't say the entire name of their firm, but I'll just say they're from Ogletree, but there's a link and you can learn more about them, and their contact information will be towards the end of the slides. But we're going to talk for just a couple minutes about those, and then we're going to jump right into talking about Cal OSHA. These folks have a lot of good information for you guys to hear, and before you decide like, hey, maybe this won't apply to me, I just want to caution you, we're not out of this yet. The requirement to protect your workers, we're going to talk about that in depth, but this is going to go on for a while. It's not going to end within the next month, let's put it that way. So whether we have COVID or we don't have COVID, we have to understand this because we don't know if it's going to come into our building. So that's why I asked these folks to come on. I listened to their presentation before. It was fantastic. I learned a lot from it. So I hope you guys can learn from it as well. So let's jump right in and talk about the AFLs that we saw come out from the department last week. All right, so there was a part 3 to the PPE decontamination systems, the Battelle systems. There was an FDA kind of emergency restriction on some of the masks were not allowed to be decontaminated. And on this third version of the AFL, there is a PDF version down below. If you scroll down at the bottom of the AFL, there's a PDF version of the mask that can be decontaminated by make and model number. And then there's it talks about the ones that cannot. And it goes into depth as to why they can't be decontaminated. Really, what you need to focus on is take a look at the masks that you guys have and compare that to the list, and then I'll tell you if you can use that decontamination system or whether you have to do something else, because certain ones cannot be decontaminated. And then the visitation limitations was updated. All they added were 2 sections to that. They talked about it at length on the infection prevention call yesterday. Just needless to say that NICU and PICU, now you can have 2 visitors rather than 1. Totally makes sense if you're a parent, you want to be in there. So, but not a lot of change for us. We do anticipate pretty soon that these visitations are going to be looked at. We heard on the infection prevention call yesterday, Heidi Steinecker and Aaron Epson talked about an AFL forthcoming. They also said that they would be passing along that information to us. We've certainly given it a lot of consideration, and we're working on expanding the visitation guidance that we put on the website to include visitation inside, and that's the real hard part. So we're going to work with the CDPH to come up with something that both protects patient safety, worker safety, and does it in a way that's not going to constitute a risk for the folks that don't have COVID in your building. So those are the things that are that happened this week. They answered a bunch of questions on the IP call. I actually thought this was the most hard data or hard information that they had given us since we began. They really tied themselves to specific things. So that was good. They did leave a little gray area about the cohorting, and certainly from the mitigation plan reviews that we've seen, that they're very particular about the cohorting they want. And that is not at all what the conversations we had with them prior to this. That's fine if they give us guidance, but if our plan, and we've thought through our plan, and the plan that we have developed creates what we think is the best method for patient care during this time, then we need to stick to our guns. I've seen surveyors look at mitigation plans and suggest other items that could compromise resident safety. I want to give everybody the benefit of the doubt, and I want to say, let's just work with them and say, look, the reason why it is the way that this is X, Y, and Z. And if you need to bring in your medical director to have those conversations, I highly suggest that. That was one of the good pieces of advice from Dr. Wassman on yesterday's call as well. And then I want to just really quickly talk about consent, because somebody asked me last week, should we be getting consent forms signed by staff that were doing the mass testing? And I don't have a template for you guys to sign, but I did talk to a couple of other attorneys that both suggested that consent forms would be probably encouraged. They didn't have a template or guidance that they could give me as to what to do, other than to say that when employee privacy is involved, you should probably at least make them aware of those, kind of the program and what you're doing. And then obviously, if not all the lab companies are sharing test results with folks, but those that are, we want to house that in a HIPAA compliant manner, because that's HIPAA compliant material. So, all right. That was the updates from this week, and I want to welcome Karen and Kevin. These folks have a wonderful presentation about Cal OSHA, and it's a really dense topic matter. We're going to dive into it, guys. If we have a chance to answer questions afterwards, we certainly will. If we run out of time, jbelden@caf.org is my email address. I think it's probably easier if you have questions about this to send those questions directly to me, and I can try to find the answer. And then maybe I can follow up with Karen and Kevin later. So I want to welcome Karen and Kevin. Please go ahead. Thank you.
Hey, we're really happy to join you here today. So why don't you, since you have control there, why don't you go ahead and get us to the next slide where we'll go through the agenda. So what we're going to talk to you is about where Cal OSHA is at today. Now, Kevin and I are dealing with the district managers and inspectors really on an almost daily basis. And the offices have remained manned. They're open. Many people have been working remotely. They've been opening investigations into fatalities and accidents the whole time since March 19th. However, they haven't been going out for site inspections as much. So they've been doing a lot from the phone, whether it's advising employers, giving permits, all that. Kevin and I have been doing informal settlement conferences via phone, telephonic judicial settlement conferences via phone. At present, we have not been able to have in-person trials. I think, Kevin, you have the first Zoom trial at the end of July. Is that right?
Yeah, that'll be the beta test, for lack of a better term, to see how it goes. We got selected to do that, so it's pretty cool. But it's a fairly straightforward case, so it's a good one to kind of get the bugs out of, because it's not a real complicated one. So we'll figure out how all that works, I guess, together with the board and opposing counsel at the end of July.
Yeah, so we're not back fully operational. You guys probably see a ton of different guidance on the Cal OSHA website. They're posting updates, and that's where their efforts have been. And then they're trying to get us back into our trials. Next slide, please. So we're going to go through some of the rules and regulations. Let's keep going. So Kevin, there are massive new workplace safety regulations. On COVID-19. True or false? Do we have a bunch of new regulations?
Well, that's a tough one, because I got a 50-50 chance of getting this thing wrong. that is false. There's actually no new regulations that have been created and passed. So to give you an idea, they just functionally almost impossible to do, because it takes a year to create a new regulation. So there are no new regulations. So everything that is currently was in before COVID is still what they're enforcing now in the context of COVID.
So when people see guidance, just know that's not a new regulation. Now, what we do have to have people do, and Kevin's going to take us through this next part. We are required in California to have our safety program. So tell us a little bit about what foundationally is required for our listeners today.
Sure. So basically, the very baseline starting point for recognition of workplace hazards is through your injury and illness prevention program, which is we hear referred to as the IIPP or the 3203, which is the section number that it applies to. It's basically California's general duty clause, if you will, because California doesn't have a general duty clause like the feds. For some of you that may have operations outside of California, you have the general duty clause. In California, they have the IIPP, which you all, I'm sure, have in place already. And so we'll talk a little bit about the mechanics of what parts of the IIPP would give rise to the identification of COVID. The next slide. So with your IIPP, there's a section that talks about assessing hazards and evaluating the risk of those. So we're going to get into the details of this pyramid a little bit later when we talk about PPE. But in essence, there's a section in IIPP that requires you when there's a new process or substance that's introduced to the workplace. In this case, COVID's a new hazard or new substance is how they're looking at it, that's introduced into the workplace. Then you have to assess that hazard and determine what you're going to do to minimize the risk and protect your employees against it. Now, in healthcare, of course, we also have an ATD standard, which we're going to talk about in depth. But right now, we're just on the baseline. First, you identify that you have the hazard, and that's through your IIPP. There's guidance for healthcare workers and employers you can find online. You see a link here on the slide. There's a lot of guidance out there. We'll try to step you through, though, what that guidance means in conjunction with the IIPP as we go. Next slide. So, when you're evaluating exposures and risk under the IIPP, you're going to look at the risk continuum, which is basically what I mean by risk continuum. Is there a low risk, a medium high, or very high? And that's going to help dictate what you're doing, what kind of exposure your employees may have versus what you need to do to mitigate that. So the higher the risk, the more mitigation and prevention may be required to lower the risk. So, for example, you're a person that may be working in billing in an office that's not exposed, that's a lower risk. They may be able to work remotely or something like that. So you're going to look at that. Let's say you're in a place and you're coming in and it's an office setting and you have pre-screening available, so the risk is mitigated. So you may wear just face coverings or what have you. And then as you go on, it kind of becomes self-explanatory. For example, one thing that I've heard a lot about is the aerosol generated procedures like intubation, those sorts of things that really aerosolize the COVID virus into the air in larger amounts. So you may have to do more, might get engineering control. I've heard of some places that have come up with a way in which to have a plexiglass covering to where the physician is doing the work with inside that plexiglass device that someone had come up with. So that's kind of an example of an engineering control, because it's a higher risk. You got to come up with something that's going to protect more than just, say, a surgical. Next slide. So how about
Kevin,
this one here? Can I ask?
I was gonna read this one for you, Kevin.
Right.
So because some people ask us this, can you tell us if we can just take the plans around our yearly flu and just use those for COVID?
And that's going to be false, but I'm going to say false again. It's probably already part of your ATD plan, your flu plans, but COVID's much different. As we know, there's different aerosolized. It's much easier to contract. There's things. So you're going to have to take, it could be a base and start, but you're going to look at what are the different mitigation factors for COVID-19. And you're going to look at the directives and the information from the CDC for healthcare and minimizing the spread and the contamination. And that's going to form, which is much more restrictive than what your flu plan would likely be. But it would give you a general baseline of where you would start. Gary, you want to add anything to that?
No, I think that there is a resource. We've been referring people, Kevin and I both, the Cal OSHA website, under their ATD information. They do have it's about a 57-page PDF booklet that you can download. If you haven't looked at that lately, it was updated in January. Kevin and I really like for our clients to take a look at that booklet. And it can be helpful in, frankly, in taking a look at some of these action items for all of you. That's the only thing I would add, Kevin.
Yeah, no, good point. Good point. And so, the different action items that are part of your plan, for the COVID-19 hazard, and if anybody that's been around for the last 2 months probably have all these by heart, so it's nothing new. And not to sound flippant, but in a way, now it's kind of what you teach your kindergartner. That's what you need to do, right? Pay attention to what your work processes are. Make sure you communicate openly and with the employees. This is where we see this a lot. This is where a lot of complaints get generated that Karen was talking about earlier to Cal OSHA, because the employees just may not be informed as why are. Giving a real world example, there was a complaint that had to do with the janitorial staff was not being required to wear N95s, but the nurses in the COVID unit was. Well, there's a reason. When there's a shortage and they're in direct contact with the patient, so you're looking at your weighing the odds, but that no one really communicated the reason why. And so sometimes that's helpful. Cleaning, making sure things are clean and sanitary, what you do every day. The training is a big component in this, making sure everyone's informed. This kind of goes back with number 2, making sure everyone knows what their role is, what their requirements are when they're doing certain tasks, those sorts of things. And then, of course, this is a big one now, and it's gotten easier, I think, as John alluded to earlier. At least it's not changing every 10 minutes now. Was the orders and the CDC advice and public health advice that's coming out, and the county departments were not even on the same page often, and the guidance was coming out, and the orders were coming out, and they were changing so rapidly. It seems to have slowed down now, but that's where you got to continuously monitor this. Now, while I'm on this topic, keep in mind that Cal OSHA has many months to issue a citation for a violation of 6 months, and there's extended that, I think, to one of the executive orders in California. But that being said, for example, when, let's say, the complaint was in February, and they're asking you what you're doing for this particular issue, let's say the N95 issue. We weren't having nurses wear N95. Now, right now, maybe there's no shortage, or they're easier to get, but at the time, there was a shortage. You couldn't get enough N95s, and there wasn't enough stockpile because this thing hit in March, and you tried to order them, and then the guidance was different. So as you're going through and memorializing the methods in which you are protecting your employees, it's important to keep the rationale for why in February were we not providing N95s, but now in April we are. Well, we ordered, here's a copy of where we tried to order them. They were 9 weeks out. We only had a stockpile of 12,000, and those sorts of things. Very important, because so that you can identify what you were doing at the time and what the guidance was. Another thing is, when the guidance disappears on the website, it's gone. So if you do a PDF of what guidance, or save the guidance that you were relying on at the time during the time period in which you were doing your risk analysis is very important. And of course, assessing how things are working, making adjustments as things go, and evaluating the work. Next slide. This kind of goes to my point earlier. I jumped ahead, but hindsight's going to be 2020. This is why it's so important to make sure you have memorialized the rationale for which you use to determine what protocols and what safety requirements you're going to have for certain tasks, certain categories of employees maybe, and what that guidance was. And if you haven't done that, I'd start doing it. The next slide. Okay. PPE, Karen, wanna?
Sure. So, you guys, if you're, in healthcare, you know about PPE and the feds and the state plans. And so we're assuming a lot of you, you have your operations in California, maybe you have some operations in other states, but there are very substantial and specific PPE requirements. You've dealt with these before. They're not new PPE requirements. It's what there always has been. And so, as far as what you've done for compliance in the past, but now we have COVID, and there is guidance around PPE offered on the Cal OSHA website, and PPE now, people are starting to talk about it more. I mean, you even see it on the news. People talk about PPE. Go ahead to the next slide. And so, oops, there you go. And PPE, a lot of the terminology under it has become conflated. For example, face masks, face coverings, face shields, all of this. There really has been a conflation. And in fact, the term face covering is not used in any Cal OSHA regulation. So true or false, PPE includes face coverings. Well, it's halfway. It's kind of true, kind of false. If you look at the gal on the left who has,
Yeah, you got the one that had both answers, so there's no way to get it wrong.
I know, right? Not very fair, but just remember what the difference is between a face mask, right, and a face covering. And even though you'll see local orders, and in fact, the order that came out from the Department of Public Health and the governor's office yesterday talked about face coverings, most of the time in your environment, you're dealing with face mask and face shields. So make sure that you're being pretty artful in your conversations, because the terminology is going to be important. Can you go on to the next slide? So Kevin and I like to take kind of a short sidebar into the hierarchy of controls. For a lot of the safety nerds out there, you're familiar with this concept and you use it, but and it's a concept used at Cal OSHA when we're litigating cases. We're putting forward that we're using the hierarchy of controls to address hazards. So Kevin, you want to take us through and explain the hierarchy of controls and some of these examples and where they fit in on this?
Sure, absolutely. So here's the irony. We've heard so much about PPE, right? PPE this, PPE that, all over the news. Well, interestingly enough, according to Cal OSHA and the traditions of evaluation of hazards, PPE is supposed to be your last resort to protect the employee. That's why the pyramid's upside down. So the first and obvious is elimination, right? So you eliminate the hazard. So physically remove the hazard, or like in our context, for example, you may have some folks that can work remotely, like say doing the billing and stuff. So that's step one. You have now eliminated the hazard for that category of employees by having them work remotely. That's you probably didn't even think of it this way, but that's elimination of the hazard. So now everything below the chart's done. You've eliminated hazard for that particular task and that particular employee. Now next is substitution. Now in our context with COVID-19, the substitution is not necessarily one that I haven't been able to come up with a good example in healthcare. Substitution necessarily, Karen, I don't know if you have, but substitution
No.
usually, yeah. Context of a machine, we find this machine that can do the same thing, and so we get rid of that machine and put this machine in that's safer, and so you substituted the hazard. Or another example could be you're using this chemical cleaner and we found one that is less toxic or non-toxic, so we substitute. It does the same thing, but we're using this other product to clean that is less toxic or non-toxic, for example. That's substitution, so you can learn it in that context. But now engineering controls. This is one I alluded to earlier. This is on the chart. You can't eliminate, you can't substitute. So engineering is your next thing you're supposed to evaluate. So in engineering control, we see that, for example, when I was talking about doing the intubation process with the plexiglass covering, that's a form of an engineering control, right? Because they don't have to wear PPE, arguably, because you have now contained through an engineered apparatus that doesn't require someone to put something on, and it provides a solid barrier. That's an engineering control. That was supposed to be the first thing you're supposed to consider when evaluating a hazard. Can I engineer the hazard out? So that's an example of that. The plexiglass barriers, ventilation systems that I think people are working on that may provide. Those are forms of engineering controls, which is higher in the hierarchy than administrative and PPE. So now, what about administrative controls? So before you get to PPE, once again, you're evaluating and say, okay, I can't engineer it out, but can I administratively eliminate it? What does that mean? Well, some acts or action that you would have as a policy for your employees to follow that would prevent them. So example, in our context with COVID-19, you see the social distancing, putting the marks on the floor at 6 foot so that people stay, making hallways one direction only, those sorts of things. Those are administrative controls. Arguably based on the hierarchy of controls, you've done the engineering, right? You've got things eliminated there, and then you've done things with administrative. You wouldn't need the PPE. I'm not saying we're not going to use PPA, but technically under the hierarchy controls, if you can administratively remove it, then you PPE, because remember, PPE is the last resort. Then if you can't, another example, by the way, of administrative controls like the temperature screening, right? Or some folks actually physically take the temperature. Some places will say, hey, fill out this form, or go online and click and say whether they have a favor or not before you come in as a vendor, those sorts of things. Most of your health facilities, though, are doing actual temperature screenings, but that's a form of administrative control. You are trying to eliminate those coming in because fever is one of the telltale signs. So that's an example of an administrative control in our context. Then we can't eliminate it that way, so now we're down to PPE. So that's your last resort, personal protective equipment. This is the N95 masks that folks are using, eye protection. You're going to see face shields sometimes, or combinations of all these things. Those are all PPE, something that an employee has to wear to protect themselves. Now, there are some argument, even OSHA themselves talks about face covering. We heard Karen mention face coverings earlier in the true false question. They are they have said that they aren't considered necessarily face coverings to be PPE, because the idea is it's not really protecting the person wearing them, it's protecting the other person, because PPE is personal protective equipment. And depending on the type of PPE it is, or the type of face covering it is, it may do both. It may be protective of the individual themselves, like the N95 masks themselves. And by the way, we'll talk about N95s for use for COVID versus respiratory protection a little bit later too, Karen. I think, right? We got that
Yeah,
coming up. So.
yeah, we have a few more when we get into the ATD. So next slide, please. So just remember, you know, in California, we've got the ATD standard for you guys. If you have operations in other places that fall under Fed OSHA, the Fed OSHA website's been getting updated a lot. There has been some pretty good guidance. One thing I do want to mention is that even though our COVID does not fall under the bloodborne pathogen standards, and we have one in California and we have our federal one, some of the engineering controls and administrative controls found in the bloodborne pathogen standards can be helpful in addressing COVID. So don't forget to take a look at that. That can be a resource for you if you're creating a little action list at your desk today. And then don't forget, we're going to run through some scenarios on record keeping and reporting. I would say probably 50% of the questions I got this week from clients were related to record keeping and reporting. So next slide, please. So in Cal OSHA, don't forget that we have slightly different, we have our IIPP, we have slightly different standards in our bloodborne pathogens, and we have a slightly different standard in reporting, and it's a little bit of a nuance. Of course, in California, we always have to be a little different and a little better. Next slide, please. So
better to look at that.
I know, right? So so if you're in any of these healthcare workplaces, you know you've got to have your ATD and your ATD plan, all of that. One thing we're seeing is that there are some establishments, let's say, that are doing homelessness service that also, based on the definitions, would fall under healthcare workplaces and would be required to have an aerosol transmissible disease plan. Next slide, please. And so if you already have your ATD plan and you're working, that's great. What one takeaway that I'd like for everybody to have is that if you get inspected, the inspector, this is going to be one of the first documents he asks for, he or she. And they're going to want to see how you're documenting dealing with COVID, if you've customized what you're doing as far as engineering and work practice controls, and also what new practices you have implemented under your ATD plan. Next slide, please. So you should make sure you have that plan ready. It shouldn't be gathering dust on the shelf. Don't forget, you can go to Cal OSHA, the website, for some guidance. Now I'm going to take Kevin through this question, and we always name our people after some of our favorite inspectors. So this is Eugene. He's a Cal OSHA inspector in Northern California. And so in this scenario, Eugene's a janitor, and he's working at a rehab hospital. And he's been using PPE, and then he calls in and tells human resources, oh, I've tested positive for COVID. Nobody else at home is sick. I must have gotten this at work. I'm home resting. I'm taking some NyQuil. I'm taking some Mucinex. And, you know, I think I'll be fine, but I'm going to stay out of work. And HR knows that nobody else in the hospital has tested positive. So here's the question, Kevin. Should Mary record this COVID-19 illness as a workplace injury or illness?
Probably not in this fact pattern. Let me kind of explain how I did that. But because it isn't like presumed, it isn't automatically work related. So you notice there's facts in there. No one else at work has had it yet. No one else has tested positive. We know that, and so this is basically patient zero, I guess, at Eugene's workplace. And so the fact that he merely was at work and ended up getting COVID-19 doesn't necessarily make it work related. Now, we hear a lot about this presumption and workers' comp and all that. That doesn't apply to Cal OSHA. Cal OSHA still must be work-related illness or injury. And so that's the analysis you're going to do. If we change the facts slightly and say one of the other janitors he was working with tested positive as well, or just after or just before, then it may be arguably recordable. I have a fatality case very similar to this, and Karen, I don't know if we had a chance to talk about this. That it was the first case. It was in a health facility. I won't give any more than that away, but it was early on, and the particular fact was there was no one else ended up with COVID-19 for some days afterwards, and so that's one where even Cal OSHA is struggling with, is that a work-related fatality because of those facts, and those are the facts we're analyzing going through based on their investigation and ours. So that's kind of real world scenario. The first one may not be, the second one might be.
And what I tell clients is you need to make a good faith determination. You need to not automatically presume that it's not work related, or automatically, because workers' comp has a presumption, assume it's work related. So make your good faith analysis. Now, as a follow-up, Kevin, should the human resources gal, Mary, should she report this as a workplace injury or illness to Cal OSHA?
Absolutely not. This one is really clear on that. Reportable means you report it to Cal OSHA. You make a phone call and tell them, hey, I had a workplace injury that meets the criteria of serious injury. And what is a serious injury? It's hospitalization for 24 hours or more for other than observation. It is loss of a body part, permanent disfigurement. And so if it doesn't meet any of those three, which this one doesn't because he's at home recovering, right? He hadn't even been in the hospital. So it's absolutely not reportable. On a side note on the recordable, and I was thinking of this when you're talking about the due diligence part, Karen, and like I said, we probably get 150 calls a week on recording, not recording, that sort of thing. The irony of that is, out of all the cases that we have, that's the lowest ticket item, but it seems to draw the most attention. It's a few $100 penalty, and if you make a mistake one way or the other, it's not like the end of the world on it, because it's a very small penalty, and you have the defensive, hey, here's what we looked at, and if you put one down that you find out, hey, it turns out it's not, you draw a line through it, and that fixes it. So I just want to calm some of the nerves about recording, not recording out there, just from a practical standpoint. It's a very low end penalty for that.
Awesome. Yeah, and if you end up with any other questions about recordable or reportable, or need a scenario run through, you can always call Kevin or me. Okay, let's start going through some of the guidance. So available online, and I wanted to make sure you guys have the link. We've got Fed OSHA guidance, and certainly just massive quantities of materials. One thing to remember is that Fed OSHA is looking to the CDC quite a bit on strategies, on information about mask, about decontamination and reuse. So that, like we said at the beginning, that's guidance. It's not a rule, a statute, a law, a code. It's guidance. Next slide, please. And then, of course, if you go to the Cal OSHA website at dir.ca.gov, there's going to be a ton more guidance. And Cal OSHA has put out quite a few checklists. If you go on the site, I want to say there's about 19 total checklists for different industries, including one for healthcare. And those are good training tools to go through and see if you can check all the boxes about what you're doing in the workplace. Those checklists are not again, not a rule, they're not a statute, but they're certainly helpful materials for you. So if you're keeping an action list for after this webinar, going and checking out the checklist and seeing if you can use some of those in your workplace, it's a really good idea. And so I like to kind of give some good action items, some good takeaways. So I hope that's one for you guys. Next slide.
Hey,
Now,
Karen, real quick, I want to jump in on the guidance thing too. Just keep in mind, like Karen has said a bunch of, it's not the law, but here's what I see the guidance as. It becomes our shield when we're doing what it is, and it can become the sword if we have a rationale for why we may not do the guidance because this past was different. So always, I just think it's important to know that it does have value in defending these cases later, even though it isn't regulatory. Sorry about that. Let me interrupt.
no worries. Well, let's go through and help you guys with understanding what you're going to need to do during an inspection. Inspections are a huge area of questions that Kevin and I get, a huge area of assistance for us. We actually tend to, end up jumping in our car and ending up at the job site quite a bit. So we've got Deborah, another one of our favorite inspectors, and she comes to the hospital entrance with her ID. And she asked to speak to the supervisor and start the inspection. So Kevin, do you have to let her come onto the premises to start the inspection?
No, you don't have to consent yet. And you don't actually ever have to consent. We're going to recommend consenting at some point, but no, we have to make sure that she has the right PPE for whatever your protocols are and safety. Number two is, and I think we might get to this a little bit, but they do not have to just automatically enter. They don't get to just barge in without consent. And you can wait for consent until you find out the details of why she was there, or in this case, she, Deborah. So, before you let them on, you need to make sure, one, they're legit, they got the ID. Two, what's their purpose of being there? So, for example, are they there for a complaint inspection? That's one thing. Are they there because they think there was a serious injury? And let me give you a little bit of example of that. Because let's say they say there's a serious injury because they heard someone had COVID-19. Let's say they heard about Eugene earlier. Well, that wasn't a serious injury, so that's a false pretense for consent because they're asking you for consent based on a serious injury that did not occur. So keep that in mind. We always want to find out what the reason for them to be there.
So Deborah's found out the reason, and you think you're gonna, proceed with the inspection. Kevin, do we have to supply her with all the PPE so that Deborah can do her walk around?
No, absolutely not. They need to come prepared, just like you were prepared for your employees. The state has to have them prepared. So if let's an example, they probably will have face covering and safety glasses and those sorts of things. But let's change it to where they want to walk the COVID unit. Well, in order to be in your COVID unit at a particular hospital, maybe your protocol is you have to have full gown and garments and both an N95 and a surgical mask plus goggles, a head covering, etc. Whatever your PPE requirement is. If they don't have all of that, you don't need to supply that to them. They need to come prepared. And also keeping in mind, don't just let them go, well, you got your face covering since you're just inspecting OSHA, we want to work with you. And stuff. You've just now showed them that you don't enforce your own safety protocols by allowing them to do it without the proper PPE. So it actually, a little counterintuitive, but forcing them to follow your procedures actually shows that you enforce your procedures, and it goes a long way later if the investigation goes on and they want to issue citation, that sort of thing. So it's one more evidence of proof that you do follow your protocols.
So we've got the PPE and walked around, and Deborah sees some employees and says, hey, I want to interview, Mary Jane and Bob. and can we get a conference room? And I'd like to talk to them for about a half hour right now. Can she interview those employees that day?
Maybe. And let me say why I say that is that, let's say Mary Jane and Bob are both nurses, and they've got 5 patients each that day, and you can't unreasonably disrupt. They don't have Calosha, they don't have the right to unreasonably disrupt. I don't care if they do want to talk to them or not. Patient care is going to come first, and then you can schedule a time later that you can make them available for them. Now, the employee holds the rights to talk to Calosha, not to talk to Calosha, have their union rep, if the union rep placed there, or a management person set with them, whatever. Calosha doesn't own the rights, and the employer doesn't own the rights to be interviewed or interview. It's the employee that owns those rights, and Calosha pretends like they own the rights, and which isn't true. And there's also a labor code that says it can't unreasonably disrupt the operations. And this is a prime example, like I gave with the 2 nurses that you used in your example, Karen, that may unreasonably, so there's no reason why you have to stop and make arrangements in the middle of your operation.
Yeah, I think I always say, oh, well, we'll get that scheduled and when we can do it safely and maintain operations. So now Deborah asks you for your OSHA 300 log, Kevin. What are you going to do?
Well, I'm going to say I'll get it for you, but here's the thing: what the law says is you have 4 hours upon request to get them the 300 log, and it's something you do. But I like to take a look at it before I hand it over and see if maybe, like we were talking about corrections earlier, maybe you want to correct something before, or make sure your T's are dotted and your I's are dotted. So you don't have to immediately hand it to them. You have 4 hours. That is the only document that has the 4-hour minimum requirement. The other one that probably doesn't apply to you guys is the outdoor heat illness, which does say immediately upon request. But keep in mind the 300 log, you have 4 hours.
Yeah, so make sure you're maintaining that 300 log. I know a lot of people do it on an Excel spreadsheet. Make sure that's updated for each establishment location. Keep it updated at all times. And if you want to add it to your action list for today, go and take a look at your OSHA 300 log today and just see, hey, do I have the ability to pull it up and print it out and turn it over right then, or is it very difficult to find? So next, Deborah tells Kevin that the office received a complaint and that there were nurses who've become infected with COVID-19, and she wants to know which nurses were infected. What are you going to say, Kevin?
Well, first of all, it's privacy. We don't have to provide them with the names, Calosha, to the names of any other nurses that are infected, and I would stick my guns on that.
And that's an important aspect with COVID-19 and with illnesses. Make sure you're following your privacy processes and your privacy rules in your entity. If you have to redact people's names and personal identifying information, you need to make sure you do that, especially if you're going to tender any documents to Cal OSHA. Don't get caught giving Cal OSHA information with people's medical details, personal identifying information, just because they're a state agency. They're not entitled to those kind of details. So Kevin, what if next Deborah says, hey, I want to interview a janitor or custodian. I want to figure out some of the sanitation procedures at this hospital. Can she do that? And what if the janitors are in a union?
What she can ask, and then we can give the same answer we talked about earlier, make them available whenever it doesn't unreasonably disrupt the operation. And 2, if they're union, then the union has to be notified before and have an opportunity to participate before you're granting those interviews, or they're doing those interviews too. So that's what I would recommend on both of those.
Yeah, don't forget, if your employees have a bargaining unit, that bargaining unit will likely want to sit in on interviews. So don't make that mistake and start setting up interviews or providing documents and then somehow stepping on the toes of the bargaining unit. Next slide, please. So now we're going to go through one more inspection scenario with Eugene, our favorite inspector up north. He comes to a skilled nursing facility, and your designated management representative, Michelle, she's over at another facility 30 minutes away doing some work there. Kevin, can they ask the inspector to wait for Michelle to get there in 30 minutes?
Absolutely. And back to our consent thing, we're kind of alluding to, do not consent until she's there. They have to wait under their P&P, their policies and procedures, OSHA's own policies, a reasonable amount of time for the employer's designated management representative to arrive at the facility to do the walk around with them. And reasonable has been defined from 60 to 90 minutes by various DARs. 60 is the lowest, I think, and 90 is the highest. So 30 minutes, you're well within that. And this happens all the time too. I know everyone's worried about balancing. You don't want to make them frustrated and aggravated. If they get frustrated or aggravated because you're having them wait for the deadline, then there's other issues that the inspector has besides that. They usually are said that's fine. Now, there have been times where, because a lot of Karen and my clients, well, we may be the designated representative that walks with them, and they'll wait for us. And so sometimes I'll get on the phone, or Karen will get on the phone with them while we're driving and do the formality portion of the inspection, where they do the opening over the phone, so they're not having to wait much. And so there's ways to work with them, but also make sure they know they aren't doing an inspection or interviews or anything until we arrive.
Yeah, it's absolutely not unreasonable. Their own policies and procedures manual tells them that they can wait. Stick them in a conference room with some water and coffee and some Wi-Fi, and they'll be good to go. So after the opening conference and during the walk around, Eugene sees a daisy chain of extension cords in the office, and he points it out. What do you say, Kevin, when Eugene points out a problematic set of extension cords?
Well, you don't say much.
Right.
So here's the thing. When Michelle's walking with Eugene, anything she says can be used as an admission against interest against the company. So it's important for Michelle to recognize and be polite and cooperative, but not offer any additional information. So in this context, what I would say Michelle's perfect answer would be, thanks for pointing that out. We'll look into that. You haven't made any, you've acknowledged
no admissions, no talking about, oh yeah, it's been like that 6 months, or oh yeah, we've been meaning to fix that. You've just admitted to employer knowledge of a violation. So it's just always good to say thank you so much. Appreciate you pointing that out. Now, Eugene asked to see someone don and doff their PPE. Kevin, what would you do if Eugene asked to see someone demonstrating donning and doffing?
I would say you take your stuff off first, and then I'll no. I would say no. We don't do demonstrations. We don't do examples. But you're welcome when folks are coming through that are donning and doffing to watch that process. Because always, let me say, almost every time I have had a client that has done a sample, an example, it never goes as planned, and it's usually worse than what the actual
right.
Or let's say I'm going to change this just a little bit, and it is, can you show us how you did the procedure for the intubation that is allegedly has exposed a nurse to COVID, right? Well, when you do that, if you do it exactly the way it was and it doesn't work, right? I've had this happen before where they recreate it, including what they did wrong. So, yeah, so you want to stay away from any demonstrations.
Yeah, we're not recreating, we're not demonstrating. They can observe. So now Eugene asked to interview the CEO of the hospital. What are you going to say in response to that, Kevin?
Same thing. CEO, by the way, CEO is management, so we have an absolute right to participate as counsel and control that interview request. And so we're going to schedule it at a time that's convenient for all of us. And we've had an opportunity for the CEO to be prepared properly for an OSHA interview.
There you go. And that same, since any other interviews of management, you're also going to have your counsel sitting there at the table beside you after preparing you. So after Eugene leaves, he's going to email you a very standard document request with a huge list of documents that he wants. Everything from copies of your workers' comp insurance to your IIPP, your ATD, maybe even an org chart. What are some of the best practices that you tell people, Kevin, in preparing the document request response?
Well, one thing that's very important is document control. So you want to review everything. You also want to I prefer to base. I'm sure you have a control number of what you provided to Cal OSHA. Now, generally, we may not always do this on just a regular straight inspection, but anything that has to do with an injury or something like with the COVID-19 is going to be big if you're having an inspection. Make sure that when they ask the document request, they treat that kind of like a regular discovery request in civil. And I will object specifically to the questions, because they sometimes will say, provide employee training. Well, what training do they want? That's vague and ambiguous. But then I'll provide what we feel like it is, but it gives us that door to supplement later. And then when I do provide documents, whether base numbered, let's say we have 10 documents they requested, and we have 300 pages of different documents with different things. We base number, and I don't go, okay, well, number 5 through 6 is applicable to document request number 1. And I'll tell you why I don't do that. Is because there's nuggets of things that may apply to 10 of those and help answer 10 of those. Once you pin yourself down to 1, then it's very hard to say, well, I really meant that applied to 2 and 3 too. So I just say enclosed
I absolutely agree.
1 through 500 and response to questions 1 through 10.
Yeah, that's kind of a little trick of the trade that Kevin and I use. So feel free to, if you ever have that scenario dealing with the document request, that's something all of us experienced Workplace Safety Council also do. So now Eugene asked for
Karen, for me, what do you do about privacy on documents too?
Oh, I redact anything that's like somebody's cell phone number that might be on a training document. Anything that's personal identifying information, because, and this is an important point, every document that we send in could be subject to a Public Records Act request, meaning either a reporter or another lawyer that has some other case, or someone with a grudge can send in a Public Records Act request and $20 and get your whole file with all the information in it. So you need to be careful with marking confidential information and redacting medical information, personal identifying information, and also marking documents that are your trade secrets or your kind of trade secrets has a broad definition, but anything that, let's say, your competitors might want to know about you. Does that sound about right, Kevin?
Yeah, absolutely. Absolutely.
So if Eugene asks for documents related to your vendors, you going to give it to him?
Well, maybe. It's only, I know there's not I'm not going to give them, I'm not going to go to the janitorial company and ask them for documents that they asked me for. But I am going to, let's say, maybe the contract with the janitorial service, you have custody and control of that. You have it in your possession, yeah, and that's something they ask for. We only have to give Cal OSHA documents that we have that are related to what the request is. And so, but what happens, and I think in this context, Karen, what you're alluding to is they say, what can I have all the training documents from ABC Janitor that they provided to Tom Kincaid, who was working at your facility? Well, no, that isn't something you have. That's something they have. They need to open an investigation against that for we're not going to do that.
So do our moderators, did we get any questions that you want to throw out for Kevin and me?
Sure, and I told them we'll go along a little bit so that we can answer some questions. Courtney, do you have any questions?
Yes, let me pull it up right here. So we have a question for the scenario about the employee who gets sick. What happens if after a few days another staff member gets sick and it is discovered during the regular testing in the SNF? Would you then have to report the employee that stayed home as a workplace injury?
Well, I think that you're going to have to go back and add that fact into your analysis. You'd have to look and see, did these people work together? Were they, within 6 feet of each other for an extended period of time? Did they carpool together? Did they socialize outside of work together? We've had that in a ton of scenarios. Any other factors that you can think of, Kevin, that you'd look to in that kind of fact pattern?
Yeah, one other thing I would look at is the time difference between the two, and maybe who got it first. Maybe the first one's not recordable, but the second one is, and so that's something you may want to look at. But like I kind of said earlier, is that if you, and with Karen was saying, maybe there's enough factors there you can't differentiate between the two, but it most likely was work. I think I just err on the side of putting it down, and on the log probably, depending on that. But for the most part, it's the same analysis. You're just going to look at what makes it work related or connected. I can give you a real world example too that Karen and I got, where we had this situation, and there's more than one person on this particular site that had it, but come to find out the person that had it hadn't been to work for 6 days, and then they worked by themselves and they rode to work by themselves. So there's no way for that second one to be work related, but and then the first one that happened on that particular site also had no contact. So we had two in that scenario that actually neither one could be found to be work related. So fact driven, these are highly fact driven, and I know everybody kind of wants a black and white answer. It's very difficult, and you have to just analyze each isolated case by itself.
Okay, next question. So this question, it's two, so I'm going to paraphrase it a little bit. We don't normally deny inspectors from inspecting the buildings. Does this apply for Cal OSHA only?
I would say, yeah, we're very specific, and there are very specific policies, procedures, and case law about Cal OSHA inspectors and what they are supposed to do on your work site and what your rights are as an employer. Kevin, would you like to add anything about that? Because I feel like we always want our clients to be professional, and when they interact with Cal OSHA, it's always from a mutual respect and polite and very mannered, but firm in any disagreements or desires for them to wait or to not provide them something.
Yeah, and let me correct, not correct, but rephrase one thing, and because I don't want us to come across as that we're denying Cal OSHA the inspection, because they're going to get the inspection. What we're doing is controlling that entry. So it isn't that we're saying, no, you cannot inspect our facility. We're just requiring them to follow the rules when they do, and making sure that we're within their rights. So we would, and although some people do deny entry of Cal OSHA or deny entry, we would never recommend that unless it's I haven't ever had a case in 20 years where I said, no.
Me neither. We always just end up, yeah, we do it, but under our time frame and with our management representative, and in a way that doesn't disturb the business or make the business unsafe.
Replace the word deny with control. We control.
Okay, thank you. Next question, and Jason, this might apply to you as well. Are the baseline test results for employees part of the employee's file?
You mean the COVID test results?
Yeah, the baseline COVID test results. Would those go in the employee's file? file for Cal OSHA purposes.
Yeah, you know, here's the thing, when Cal OSHA asks for, if they ask for anything related to a COVID test, that's technically a medical record. They have to provide notice to the employee that they're requesting their medical record. That gets a little in the weeds, but it's not something you're just going to turn over. That's something you're going to have to work with your counsel about. And make sure that the employee doesn't have their medical records tendered to Cal OSHA without their knowledge or permission.
Okay, thank you. And then this is our last question. If an employee comes to work and is not feeling too well, then at the end of the shift was not able to finish her shift, therefore the employee went to the hospital and was informed that she had a mild stroke. The employee was admitted. Is this event reportable?
Reportable. You know, Kevin usually runs through a scenario with a heart attack where he talks about a heart attack being reportable. Do you want to take this one, Kevin?
Yeah. So the one thing that I'm not clear is, did this the stroke, you called 911, they were having a stroke at work, called 911 and they take it, or she wasn't feeling good and just went and it turns out she had a stroke. So I understand it. And let me just, I'll go through both. If the first, where, hey, person's at their desk and they feel like they're sick and they're having a stroke, and 911's called, they take them to the hospital. They're hospitalized for over 24 hours as a result of that, because the stroke happened at work and all of the 911 was called, so the fire department reports that. That I would say you report, and it's only, you're going to report it and nothing's going to happen, because it's not going to be a work-related stroke. But if the hospitalization occurred from someone at work, something that was occurred at work, then it's reportable. It's a very nuanced. But let's say she just wasn't feeling well, she goes home, or she's on the way home, she says, you know what, I'm going to stop not feeling, I stopped the ER, and it turns out she had a stroke at some point prior to going in the ER. I would say that's not reported. The scenario I get with the heart attacks happen often, it's usually a fatality where they have a heart attack at their desk, and then no one thinks that that's reportable because it was a heart attack at the desk, had nothing to do with work. But the law says where serious injury or death occurs at the workplace, not related to work, but at the workplace. That's nuanced. But here's the thing: if in doubt, avoid the citation of $5,000 penalty. Call them and say, hey, here's what happened, and they'll probably say in that scenario, this isn't reportable, don't worry about it. But you have a document that said, hey, I called them at this time on this time, and they said that this wasn't reportable, and then you're done. Because with this much going on, they aren't going to want to come and inspect. Even before COVID, they didn't have time to inspect.
Yeah.
Fair enough, Kevin.
Well, I want to thank you guys immensely. We went a little bit long. I want to apologize to folks that had a 2 o'clock call to get on, but I can't stress enough how important for this is for your financial viability as a business, during this and then after COVID-19. It's incredibly important for you guys. So I want to say thank you guys. Both Karen and Kevin's contact information is listed on the second to last slide. It's in the handout, so there's a PDF version of the slides in there, and webinar links as well. So I want to say thank you guys from the bottom of my heart. Our membership greatly appreciates the information. And if folks need to contact either Karen or Kevin, Kevin, you're based in Southern California, and Karen, you're Northern California, is that correct?
Yes.
Yeah.
Okay, so you guys, you now have 2 experts in your Rolodex to talk to about this stuff. So please reach out to them if you have questions. And thank you once again, everybody. Have a great weekend, okay?
And
Thank
for
you.
everyone, thank you. And for everyone that's listening, we do have a CE hour available. You can fill out the evaluation for that on caf.org. and we will be sending out a YouTube link for today's presentation with the slides. Thank you.
Awesome.
Thank you,
All right,
guys.